Welcome to Melanoma Insights for Professionals, brought to you by Melanoma Institute Australia. I'm Professor Georgina Long, Medical Oncologist and Medical Director at Melanoma Institute Australia. We're excited to bring you this special vodcast series, Redefining Immunotherapy, Lessons from Melanoma. Over the past decade, melanoma has really been at the centre of the immunotherapy story, driving some of the most meaningful advances we've seen in oncology. From the early days of checkpoint inhibitors to combination approaches and now neoadjuvant strategies, these developments have not only improved outcomes for our patients, but also changed how we think about cancer more broadly. As immunotherapy expands across multiple tumour types, including through broader multi-indication approvals, there is a growing need to share what we've learned more widely. In this 5-part series, we'll explore and discuss our experience using immunotherapy, specifically checkpoint inhibitors, in a practical way. We'll look at how immunotherapy is reshaping our thinking in cancer management, how we can make better treatment decisions, how to recognise and manage toxicity earlier, and how evolving strategies in melanoma may inform practice more broadly. We'll also take a balanced look at where the field is heading, what's likely to change practice and what may not. Across the series, you'll hear from experts working at the forefront of immuno-oncology, sharing perspectives grounded in both research and real-world experience. Joining me in the studio today are my medical oncology colleagues from Melanoma Institute Australia, Professor Alex Menzies and Associate Professor Matteo Carlino. We are also joined by Associate Professor Inês de Silva, dialing in from Portugal. In today's episode, we are rethinking how cancer is managed in the era of immunotherapy. Welcome, everybody. This is fantastic to have you here in the room to discuss something we're so passionate about, and that's curing cancer with immunotherapy. So, this first episode, let's talk about immunotherapy. Let's talk about how we're in this era. How do we rethink about immunotherapy and the immune system and fighting cancer beyond the tumour? What is immunotherapy? What do we mean by that? So I'm going to start with you, Inês. Tell us about how cancer hijacks the immune system.
Yes, thanks, Georgina. This is really one of my passions, try to understand this interaction, which is very complex, okay? That's the first concept we need to understand. And we try to simplify in this circle, right? So basically trying to understand all the steps. So basically we have cancer in our body that we should not have, right? And we have the immune system trying to identify, and that happens also with infections, right? So the immune system is really surveying, trying to understand what is there that should not be there, right? But then, so if that works, the immune system should be able to destroy every single cancer cell that appears, which is not true. Otherwise, we'll not have cancer progression. So for sure, this optimal and ideal system does not work sometimes, fails sometimes, and that's why we are here to discuss this. So when does it fail? Well, several mechanisms, and I'm sure I'm missing many others. So it's when the tumor is able to hide from the immune system, or really suppress the immune system. So by hiding, what do I mean by that? Well, the way the immune system identifies the tumor is by identifying specific molecules, for example, what we call antigens, so that are distinct from our normal organs. If the tumor is able to hide from, like, not expressing those, right? Suppressing that expression. So basically they mimic a normal organ. Another way is, okay, the tumor is expressing, for example, those antigens, but then our antigen presenting cells, our immune cells that are professional doing that, like, for example, dendritic cells, their job is to capture those molecules, digest, and show to our effector T cells. Able to do that, so that's another problem. And then the other final comment is when our T cells are not able to really effectively attack the tumor, okay, for different reasons, either because they are not good at doing that, they don't produce enough interferon gamma, they're not active enough, they did not learn the lesson well, if the dendritic cells did not teach well. And then finally, if when they go there with a lot of energy, go to the tumor microenvironment, they're ready to attack, but the tumor decides to produce suppressive cytokines, for example, or there are bad cells around like Tregs or myeloid suppressed cells that basically protect the tumor or basically suppress the T cells, trying to explain a very complex system within the circle. But basically, we have to think in a dynamic way, immunosuppressive or a tumor that wants to hide and the immune system that wants to identify and attack. It's never a yes or no, it's a balance.
Alex, I can see you're keen to add some comments there.
And well, I was just going to say, I mean, and Anesh has said it very well, you know, in summarising what is known, because I think there's a lot known, but there's a lot unknown. As she really said, I think the crux is cancer cells being made all the time in the body. Usually, 99% of the time, the immune system eradicates them, but there is some factors that happen that mean that the cancer can then sort of abide in the body and not be eradicated by the immune system. That's called equilibrium. And then there can be a point when the cancer escapes. So this is why people have a melanoma, have it cut out, 10 years later it comes back. Something changes in that environment for the immune system to not be able to control it. I think you might have mentioned here, we've talked about how cancer hijacks the immune system.
Doesn't hijack it.
Exactly. I think that is a very checkpoint immunotherapy view of that.
Yeah.
Because checkpoint immunotherapy works by removing that potential
hijacking.
Right. Hijacking.
Yeah.
But, you know, cancer is just doing what it does. It may be the immune system's the fault, not the cancer.
I've got a question for Ines, and I guess the question is, does this apply to all cancers? So one challenge we have is we all come from a skin cancer melanoma paradigm. So it is very clear the interaction between the immune system and skin cancers. We all have seen patients, particularly before we got checkpoint inhibitors, had a spontaneous regression of their melanoma.
Yep.
Right? We didn't see many, but we all have seen a few.
I've seen two.
Yeah, and I remember my first one like it was yesterday. I have a photo of him I occasionally use in talks. The other setting we've all seen transplant patients who have more cutaneous SCCs than they can ever count. Two really good examples before you even talk about a checkpoint inhibitor of why the immune system is so important for our cancers and many other cancers.
So immunosuppression,
More
they
cancer,
all go up in
or
transplant.
Something happens in the immune system, cancer disappeared. I think that no one would begrudge that.
They're the two extremes,
But are there cancers where the immune system doesn't matter, Ines? And I don't know the answer to that. Let's say, taken to extreme, a GIST.
I would say that immune system always matters, to be very honest. Always. Now, I agree with you. When it's established, right? Because we're seeing just the end point of the iceberg. When it comes to our clinic, because we are medical oncologists, what is a big problem? When it's established, then I agree with you. If you don't touch the immune system, of course, the immune system is more relevant or active in case of a melanoma. It's easier to tweak. It's easier to manipulate. Exactly. Having said that, my future, I think the way I see the future is a way that if you go to other, we'll talk about cell therapy at some point in our podcast where we'll discuss all this. But basically, novel technologies will be able to most likely overcome that resistance to immunotherapy that most of the cancers have still, right? Sarcomas, like you mentioned, GIST, breast cancer, except the triple negative, but most of the breast cancer, colorectal, so pancreatic cancer. I really believe that, of course, melanoma, very responsive to immunotherapy, so it's easier to manipulate and be successful. For the other cancer, we just have to be smarter.
Yeah.
But I still think the answer is going to be immunotherapy.
Yeah, I agree. We hope that, and we agree. We've just got to learn. We're in not even kindergarten. We're in preschool when it comes to leveraging the immune system against cancer and understanding how cancer hides from the immune system. But you nicely pointed out the antigen presentation, the building of an army, the travel of the army to the tumour, and then the army trying to kill the tumour. At each point, there's ways that the cancer can evade those steps.
Or the immune system can fail.
Or the immune system can fail. Either way, what do immune checkpoints, where we've had the most success to date, do? So you've got that immune system, you've got immune evasion. What do they do?
Perhaps I think the most surprising thing about checkpoint inhibitors, and I think if you list the PD-1s as the simplest one, is how bloody simple they are. You've got one interaction, or two, if you say PD-1 with PD-L1 and PD-L2. Yeah. One interaction in this, so you get the cartoon.
So where's PD-1 and where's PD-L2? So PD-L1 and PD-1, sorry. Where's
so
PD-1?
The PD-1 on the most simplest diagram, and it gets more complicated exponentially, but the cartoon I can draw, and it's the only one I can draw, is where the PD-1 is on the T cell, the PD-L1 is on the tumour cell, and you just block the one thing and then everything melts away and I'm a genius.
Yes.
Now,
so let's just talk about that.
Tumor microenvironment, right?
Yeah.
Tumor microenvironment.
So you've got a bunch of tumour cells. They're expressing PD-L1. You've got some T cells that are expressing PD-1 because they've been stimulated. They've had antigen stimulation, so much so that they're now exhausted. So they're expressing PD-1. That handshake, PD-1 to PD-L1, says, "Oh, you're my friend." So then the tumour is saying to the T cell, "We're friends."
The T cell won't attack it.
The T cell won't attack it, and so what we do with our drugs is put a barrier in there.
Isn't it too simple?
Yeah.
It is too simple, but that's the simplest way we explain it.
Yeah, and it's amazing it works so well.
So PD-1 is a brake. It stops the T cell from getting activated, and when engaged with PD-L1, it switches it off. So we're stopping that brake handshake, that friendly handshake, by putting in a checkpoint inhibitor so the T cell can get activated against the cancer. So that's in its simplest form. CTLA-4, different. It's at another point early on in the immune system when a T cell is first seeing an antigen presented by antigen-presenting cells, professional cells, which say, "Hey, immune system, do you think this is abnormal or not?" And if CTLA-4 is engaged, the T cell will say, "No, this is not abnormal. You're my friend." And we're blocking that. So they're checkpoint inhibitors, just to give us a baseline.
And I think the other thing, just to remind people, is that those two cartoons that you've seen in so many editorials or talks are really good. They're very helpful to explain to patients. But there is complexity, and there's a complexity that we sometimes think we know and complexity that we obviously don't know. And I think one of the good examples of that is this vogue probably about 3 or 4 years ago.
Oh, don't tell me hot versus cold.
No. I didn't want to do that to you. But this vogue of manipulating CTLA-4 molecules to get different CTLA-4 effects.
Yeah.
So the Treg effect, this effect.
It didn't work.
And I think every company had multiple CTLA-4s. Mine was always better than yours, depending on which company you
They told,
to be honest.
The fucosylated, the Probody, the this, the that, none of them did any better than ipilimumab.
Correct. But it was really, and at the time it told us how much we know about the immune system, but then in the same breath, how little we know.
Exactly. So how immunotherapy can work in other ways as well. We've just mentioned checkpoint inhibitors. That's where we've had the most success. But because it's so complicated, there are other nodes that you can try and attack, which is what we're working on.
And probably the best
trials.
Historical one, really, is the use of IL-2, as an immune stimulant. So IL-2 never really got used in Australia, but in the US, high-dose interleukin-2 was used
cytokine.
And so, in simplest term, a T cell stimulant was given, and there was a very small number of patients that potentially are cured of melanoma by stimulating T cells in a different way.
So how does immunotherapy in general, which is all about the immune system killing tumour, right? At the end of the day, immunotherapy, however you do it, however you attack the cycle, is about the immune cells killing the cancer, recognising and killing the cancer, not seeing it as a friend. That's immunotherapy. How does immunotherapy differ from targeted therapy and chemotherapy?
So Ines will know more than me, but one thing that I think the reason why immunotherapy perhaps cures things more often than others is when it works well, our response is not narrow. So whatever the treatment is, be it PD-1, it's not specific to one antigen. IL-2, it's not specific to one antigen. If you look at some of those other treatments, BRAF inhibitors, it's specific to BRAF.
I beg to differ a bit.
S-phase specific
yeah,
chemo.
but one is direct killing of the tumour cells. Chemo kills the tumour cells directly. Targeted therapy kills the tumour cells directly. Immunotherapy is a secondary thing. It gets the immune system to do the work. So
Fair,
it's
but-
actually very different.
Agreed, but I think
One's
the thing
direct,
the
one's not.
bonus is that
And one's
breadth-
flexible.
Yeah, and the immunotherapy is where I think, well, is that going to work in a heterogeneous tumour? Are the narrow immunotherapies? And we may talk in the future about CAR T cells, which are great for homogeneous tumours like lymphomas, less exciting, and maybe
solid
in my mind,
tumours.
I think they're too narrow.
So just to summarise that, chemotherapy, targeted therapy are direct cell killers. They're like weed killers, whereas immunotherapy is not direct, as in the drug is not direct. We stimulate the immune system, and the immune system is adaptive by nature. It's built to be adaptive, not to attack self, to attack infections, to attack viruses, to eradicate cancer cells. Sometimes cancer cells are smarter, but it's still got that flexibility, which is what you guys are talking about when you talk about antigens.
And I guess the other thing I was going to say is this is why, and we'll talk later about the duration of
treatment.
immunotherapy, the duration of treatment, the assessment of response is different with immunotherapy than these other drugs. So, yeah, the harbinger of targeting chemotherapy or treating the tumour is resistance, whether it be pumping drugs out of the cell, whether it be upregulating certain proteins in the cell that we can't overcome. They're inherently designed to fail. And if they don't fail, they're inherently designed to need to stay on them forever. Whereas with immunotherapy, and again, we don't know how it works, and in a heterogeneous tumour that may or may not be expressing X, Y, and Z, PD-L1, etc., maybe it's the kickstarter. Immunotherapy is a kickstarter that drives a broad effect. We've thought for a long time that targeted therapy or chemotherapy might enhance that kickstarter effect when given with immunotherapy. I don't really think it's panned out really
it
in any
hasn't.
tumour.
we've done trials that show it doesn't.
It's only not in melanoma,
synergistic.
and I don't think in others. But yeah, so it's a different
disappointingly
thing.
so. We really had this early thought translationally that it would. The idea that when
More
you,
T cells came
Yeah,
in, so therefore it must be better, but they were
so
not
the idea that when you give a BRAF inhibitor, the amount of T cells in that tumour goes through the roof. I think in some ways we thought it logical. You'd give it with PD-1, it would be better. It didn't pan out. Certainly, every radiation oncologist wants to remind you that the radiation, sensitizes the tumour to the immune system. Everyone who has a new injectable always has to lead to immune activation, right? And
injectable into the tumour is what you're talking about. They're like an intratumoral injection,
but
which treats one thing.
yeah, and some of them definitely do that. The ones that you're injecting, some of those viruses like TVEC, which actually has an immune stimulant in the virus, but to be fair, it hasn't panned out.
Not for the next cure, not like PD-1 and the checkpoint inhibitors. But the other point is about immune memory. So it's these cures. Like Alex nicely explained, targeted therapy, chemotherapy, there are so many ways for cells to become resistant. But in immunotherapy, why don't we see the same level of acquired resistance as we see with chemo and targeted therapy?
So I think the question is, and we haven't done this enough, is there complete eradication? When people's scans go cold and things disappear, if we cut out the lung met that looked like it had gone cold, is there viable tumour left behind?
We have done that. Ben Kong was the first author.
No, but I think often there isn't, and most often there isn't. So I think immunotherapy eradicates 100% of the tumour most often.
So I remember, I'll give an anecdote of mine.
And there's memory.
Yeah.
I don't know about that. At least there's memory. So that,
exactly.
yeah.
I'll go more for the memory. In fact, I think in some cases probably eradicates completely. Again, this is an area that we don't know for sure, right? Because no one goes there and resets every single thing that we see on a scan. But I believe that a good proportion of patients, probably the immunotherapy eradicates everything. But I'm with Georgina. I think there is a subgroup of patients that probably there's still a balance there. There's still some
So
tumor cells
that's
there.
interesting. So that,
But the memory is important, because sometimes we'll also have the odd case, and I had one recently, that very good response with Ipi-Nivo, that normally you'd say this patient is cured. And then normally it's after a trauma, some kind of trauma. There's a switch probably, and there's a progression, but after a complete response, there is a new progression. And really, that's very odd. That's not the common pattern, okay, just to highlight this. But that makes me think that in some cases, we still probably have some tumor cells there, but the immune cells with the memory capability, which is the effector memory T cells, are very important. And this is kind of the rationale for a vaccine, right? Very small proportion of those cells, but those cells are potent. And when they see those tumor cells again with the same antigens, they can proliferate and they're able to defend our body from those cells. I believe that's part of the mechanism.
yeah, and this idea, and one of the things that astounds me still, and this is a pre-immunotherapy, we all have patients where they had a melanoma or another cancer 25, 30 years ago, and they recur so late. I think my record of a uveal melanoma patient who was 30 years after her primary.
One of our first patients on the BRAF trials back in 2009, 30 years, 35 years.
Yeah, it's just amazing.
Yeah.
And so I think different things for different patients. I
Yes.
think there's a significant proportion of people who are eradicated. Certainly, I think the very, very late recurrences are either loss of memory or loss of equilibrium for whatever reason.
But which differs, that's what we're saying. But Alex was saying he thinks some are completely eradicated.
I think it's
so there's
significant.
no
I think the
equilibrium.
majority there is eradication.
Then you don't have equilibrium.
No, correct. No,
'cause they're
I
not
think the
there.
majority are. I think my gut feeling is the majority are cured. And certainly we've done a few resections. I think one of the best anecdotes of my career, and Georgina remembers this patient, I had a young patient who'd been on a phase 1 study, and he would not stop his immunotherapy, rightly, because before he went on that phase 1 study, he truly thought he was dying. He'd got ready to die.
Yeah.
We had many discussions over years. It was,
Did he stop in the end?
Yeah, no, but the agreement was we had to biopsy him to prove to all of us,
Yes,
to be
there
fair,
was no
his
active
partner,
cancer.
myself, and him,
Yeah.
that he was safe to stop. The biopsy wasn't easy, but the reason I remember the anecdote, the first biopsy report said viable melanoma. And then we got it reviewed by a melanoma oncologist who said these are melanophages, which are essentially macrophages that had eaten melanoma. But certainly that first biopsy report led to a fair bit of anxiety amongst the three of us.
Of course.
His partner, myself, and
Yeah.
so I think he's one of those. And I no longer see him. I occasionally, but
So, I mean, we had a nice discussion there. We're going to have to wrap up that discussion. I think, again, we could be talking for hours and theorise, but the main points were immunotherapy is a bucket of many different drugs, basically leveraging the immune system to kill cancer, very different from targeted and therapy and chemotherapy. We see durable responses because of its flexibility. We're not sure how much is complete eradication of cancer cells or memory, so that if they ever rear their ugly head, we eradicate it. Maybe a combo of both. Very different from targeted and chemotherapy, where you have many ways of developing resistance to drug therapy. And we basically covered off on how how checkpoint inhibitors actually work to take the brakes off that immune system against the cancer. And we're now going to move on to some great episodes on the practical clinical use and the future of immunotherapy. So thank you all for the discussion. Thank you for joining us for Redefining Immunotherapy Lessons from Melanoma, brought to you by Melanoma Institute Australia and made possible by an unrestricted educational grant from Bristol Myers Squibb. We acknowledge the Camaragal people as the traditional custodians of the land where we have been recording today, and pay our respects. This discussion was accurate at the time of recording, April 2026, but may not reflect the rapidly evolving treatment landscape and approvals in Australia. For more practice-changing education, sign up to our Melanoma Education portal at melanomaeducation.org.au. Thank you for listening.